Hi, and welcome to the Postpartum Years podcast. I am Mary Ellen Kramp. My doctorate is in physical therapy. So, yes, you heard that right. My last name is Kramp, and I am a physical therapist. And the only thing that makes that even better is one of the biggest areas that I treat in physical therapy is OBGYN stuff. Do the gods have a sense of humor? Yes, they do, just based on the name and what I do. I am going to introduce my friend here, Lauren. Lauren Mansell is a physical therapist as well. She has her Doctor of Physical Therapy degree from Governor State University. She has a bachelor's from Northwestern in psychology and sociology. Prior to becoming a PT, she worked as an advocate in mental health, as a mental health practitioner and a firefighter and an EMT. Her specialty certifications include she's a certified lymphedema therapist, she's a pelvic rehab professional certificate, and a certified yoga therapist. She's co founder and board member of Pelvic Health Research Initiative and is a research member of the International Continence Society and North American Menopause Society. And she is part of Governor State University faculty, and she teaches special topics, pelvic rehab, PT, wellness, and pharmacology. She has her own practice, also treats pregnancy related issues, menopause related issues, pelvic pain, lymphedema, lymph node transfer, yada, 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 bowel bladder, sexual dysfunction. She has also been published in peer reviewed journals with multidisciplinary care surveillance, and she teaches trauma informed care and is a member of a faculty of Herman and Wallace Pelvic Institute. Whew, this goes on. And she, as a 2017 fellow of Chicago Trauma Collective, she is a trauma sensitive practitioner whose goal is to empower patients and create meaningful, healthful lifestyle changes and improve their quality of life. And because she only does those things and has a family as well, she's obviously bored. So she decided to also go to acupuncture school and get a degree in acupuncture. So welcome, Lauren. Now that, our time is almost done after your bio.
Oh, thank you. Such a pleasure to be here.
So let's talk about trauma. So if we can start with defining trauma, there's the little t trauma and there's the big T trauma. And can you explain the difference?
Absolutely. And what's interesting is that as a lot of the things that we hopefully will get to, it depends on who you're talking to. So if you're talking to the general public, big T trauma would be like the trauma centers. There's a big injury, physical assault to the body. So that would be a big trauma. Whereas the little t trauma is the emotional, psychological effects of any unwanted event. That was kind of where we were at 15 years ago, I'll say, as to big and little trauma, big T, little t trauma. And now that trauma has become so much bigger and kind of part of what we should be looking for and integrating into our practices and into just being a human working with other humans. So it doesn't have to be professional. This can be, working with our loved ones, our relationships, our coworkers. When we look at big T trauma and little t trauma from a mental health lens, then we are looking at a big T trauma would be a physical injury. It would be an assault, being part of wartime, having experienced a natural disaster, having been diagnosed or treated for a life-threatening disease. These very large loss of control experiences. Oh, it doesn't have to be to you either. It could be you're watching someone else go through that. That can be under the big T trauma. So having a loss or a death of a loved one or seeing violence occur. And then there's the little t trauma now in mental health. So that's the reoccurring smaller traumas that give us a cumulative effect of what a big T trauma would give us. They're a little bit more hidden. They can be, the effects of racism, the effects of misogyny, bullying. I mean, the list goes on and on. Experiencing a divorce, childhood illness, childhood disease. And so these are those smaller accumulative effects of trauma. So it's kind of confusing, right? Because we have a big T and little t trauma for general population. And then we've kind of taken that now and blended it more into, well, what kind of trauma would someone be experiencing in the socio-emotional or the psychological type of trauma?
What sort of traumas would you expect to see in a postpartum population?
Whenever I'm teaching about trauma, I talk about it as if it's an unwanted event. So any unwanted event would be something that I would be looking for in others or myself as to how one is feeling about living within their realm and their environment. So a lot of times this comes down to lack of control or no choices or less choices. So a traumatic event could be an emergency C-section. It could be having had a forceps or a vacuum for instrument-assisted vaginal delivery. It could be reduced antenatal care. It could be comorbidities coming in. It could be intimate partner violence. So all of these things contribute to increased rates of trauma during the time of pregnancy or postpartum. This could be just our normal living also. This could be having experienced big T trauma or the other traumas or the accumulative effects that we just talked about with little T traumas. It all kind of gets boiled up during pregnancy for a multitude of reasons. And delivery is oh gosh, Mary Ellen, it's like, it can be warfare. Like it can literally be this, where you go in and there are so many things that can complicate a delivery and so many heroic means that are occurring that have consequences.
That definitely happens a lot. We both see a lot of women who are pregnant, and then for these people to have their plan for delivery, and they go in with their plan for labor and delivery, and things just go sideways. I know every person has their birth story for each child that they have given birth to, because it's so upfront and so impactful as to what's going on and so important in their lives. And yeah, the experiences can be super duper traumatic. And then there's the trauma from the mental standpoint that happens, but there's also the trauma that we see quite a lot and that we're treating quite a lot from the physical standpoint. So you have the trauma from both sides, and the I see a lot of women where the physical trauma is really grasping them mentally. I don't have control of my bladder anymore, or I don't, I'm having a lot of pelvic pain, or I've got prolapse. I've got all these physical things going on that I was not expecting to have. Why doesn't anybody talk about this? And so they have all this mental angst from the physical trauma that had occurred with the delivery as well. So let's circle on back to the anatomy, neurobiology, and physiology of trauma.
When we are discussing anatomy, so here's my little half brain with some of the brain features that we'll be talking about here within the brain. And I actually like to use my little hand puppet brain because my hand's so much better of a brain than actually the structure is. So when we're breaking down the terms, anatomy would be the structure of the brain and even the nervous system, so our nerves and how it affects our organs and muscles. So the anatomy would be the structural component. The neurobiology and the neurochemical is how there are changes to the brain and nerves because of having the experience of trauma. And then lastly, physiology is how the structures and then the cascade to the functions is then creating dysfunction and disharmony within the immune system, within our musculoskeletal system, within our endocrine system. So it's kind of, they're all interrelated and it's like a cascade. So my favorite way to kind of bring up trauma in general. So we're going to talk about trauma in general, and then just let's add on the extra layer of pregnancy and delivery and just how complicated this just you're literally dumping gasoline on a fire. Like just there's in every single case. So our amygdala is in the center of our brain. So very much in the center here, and it's it's very, very, very old. Sorry, my amygdala is my thumb. And so this is the side of the brain, so brain stem, amygdala very much in the center, and then this in the front is the frontal cortex. So the frontal cortex helps us with all of our decision making. I hate using the word rational, like rational decision making, right? Blaming and shaming everyone. Uh, so the frontal cortex, prefrontal cortex also, this is what keeps us as like functioning, harmonious humans during the day. And then when our amygdala gets triggered, it's incredibly old. It's reptilian. So that's how old our amygdala is. It's very good for helping us respond to traumatic events, fear, and anything that's, fear or highly emotional. The amygdala will kick in and help us kind of decide like we have to survive. We aren't going to talk about having a relationship or being friends or like, having a social aspect to our lives. When the amygdala is triggered, it is all about, is our body going to freeze and protect ourselves? Because we actually, the brain and the body have decided that we're going to die. So that's that freeze component that is probably the most difficult, the most important and difficult sign to see within ourselves and others and our patients and our fellow new moms. So the amygdala will overrule every other structure in the brain and the body. The amygdala, we have the fear and emotional center. Hippocampus is really huge for memory, and we know in trauma we have memory loss. So they used to blame a lot of this on oxytocin, which I think is kind of interesting because we've never really looked into, well, it's a bonding hormone, so why would it change memory? So there's all these things that they'd be like, oh, you don't remember because of oxytocin. But wait, it's a bond, right? It doesn't make sense. Like that's our feel-good bonding. Why would you lose your memory during that? Interesting. So some of the stuff we even used to be told about how postpartum our bodies are being affected physiologically, it's been very difficult to weed out where this is coming from. We know that trauma affects how our brain functions, how our memory functions, and then if this kind of keeps rolling, then we have a cumulative dysregulation of our autonomic nervous system, which helps us just kind of do all of our reflexes during the day. It's problematic. All the things that we're just having to do, not thinking. And then endocrine system, which is a lot of our hormones, and then muscles, how our muscles are responding to our environment, and then lastly, immunity. So all these things can be hugely impacted by having both big and little T traumas.
You talked about the freeze response and how that was one of the hardest things to recognize in someone. What are the signs that, a partner or another family member might be able to recognize? Because I named this podcast the Postpartum Years for a reason, because 6 weeks is a farce. After 6 weeks, then you're better. Or, well, it took your body 9 months to have this baby, so it's going to take your body 9 months to come back. And it's like, yeah, that's not it either. So, you're once you're postpartum.
Forever, right? Forever. We are changed, in good and bad ways.
Yeah, so we're forever changed in good and bad ways. I definitely agree with that. But when you're talking about the freeze phenomenon in postpartum, like what are the things that a partner, family member, friend can recognize in someone who's really struggling post trauma?
This is when a person kind of goes more inside themselves. So you'll see shutdown, you'll see social isolation, you'll see less engagement. So the kind of crossover with postpartum depression is huge, right? Because we, you know, there's all this, well, you're not bonding appropriately with your baby. I'm like, can we please stop guilting and shaming everyone? For reals. So it's this kind of retreating back into one's body. So it can show up in, love the word, anhedonia, which is loss of pleasure. So not doing those things that we used to do for ourselves. It can be, changes in eating, changes in drinking, changes in sleeping, all of these, like, where we're just kind of like acting it out, where our loved one is just kind of retreating into themselves a bit. So if you feel less engagement, I never want this to feel or be blaming or shaming in any way. If someone's kind of needing more sleep, that wouldn't be the biggest indicator, because we need a lot of sleep postpartum. But if there's a shutdown, if there is a sadness, the Edinburgh postpartum depression scale, it can be administered or looked at any time, just to kind of look for some of these more depressive shutdown symptoms.
What do you see as far as, let's see, flight, fight, freeze?
This was brilliant. It's all Stephen Porges's work starting in 1990s. And they took freeze and put it over to a parasympathetic, which everyone's like, wait, what? Parasympathetic is supposed to be rest, digest, and heal. So parasympathetic is when we're like cuddling our people, when we're loving, when we're eating. The reason why I think the freeze was so important to go into parasympathetic is because our vagus nerve is super old, super powerful, and it literally wanders throughout our body. It's vagus for vagrant, wanderer. So when the parasympathetic, this is the dorsal, the backside of our spinal cord, when it engages into a response and we freeze, it shuts everything down. So freeze now is in that dorsal vagal. And then fight or flight is sympathetic nervous system. I love fight or flight. Even when patients start fighting and flighting to me, I'm like, okay, they're activated. Someone in fight or flight has a much better prognosis because they feel engaged. So they're either running towards, which is fight, or running away. They're activated. They're literally, their skeleton muscles like, okay, we are out of here, or we are running at you. There is less guilt and shame in fight or flight than there is in freeze. Because in freeze, it's another, I had no control. Something just happened in our brains where we just shut down. And then it's like, I didn't fight back. I didn't do this. I didn't respond. So there's all of this guilt and shame that goes along with the parasympathetic, the specific dorsal vagal, that is, this needs to be taught in like grade school. Like this needs to be like, it's not your fault, right? Like
Hmm.
it's kind of gotten much bigger, but I like fight or flight, because if you're angry, you are activated. If you're, even if you're crying, if you're upset, you are activated. When somebody is not angry, when they're not sad, when they're not processing, those are the new moms, or those are the people that we need to build our army and make sure that we are kind of pulling in our whole team and getting help. That to me is the hardest to treat, the hardest one to help move them, in all of the ways, structurally, with their anatomy, with their, in all the ways, pelvic floor, with their brain, with how the cascade goes. Being stuck in dorsal vagal really impedes healing. So we have to identify that and help them through, even when that means that others will fight or flight us. Yep. I will. So it's just understanding, like when somebody like gets mad at me and fires me, or something happens and that, I'm like, okay, well, I definitely want to talk through this, but this might be something that is nervous system triggered, and can be a really good opportunity for growth and moving through. It's uncomfortable, but it's also incredibly important. And then in the background, I'm like, well, it'll help their healing. So
I had never heard it put that way versus, the sympathetic versus the parasympathetic, with fight or flight and then freeze, being in those two different categories. And that makes sense too, because I just think back to the three deliveries I had. I had two rather easy vaginal births where it was like irritated with like some of the nurses versus or irritated with one of the doctors. And then my third was quite a traumatic birth where um, everything was going just fine. And then all of a sudden heart rate started dropping. I had worked in this hospital on a different floor and in inpatient rehab. And whenever I heard stat calls to 3 North, I knew that was labor and delivery. My heart just was like, oh, that poor woman. And to hear those stat calls for me was like, oh, that was awful to hear, anesthesia stat 3 North, anesthesia stat 3 North in here. No, that's
Mm-hmm.
that's for me. And, being rushed into the OR and being even though I had an epidural, to change that epidural from what it was doing to a spinal for the C-section, it wasn't fast enough for them to be able to do that. Because when I talked to an anesthesiologist later on, I'm like, why did you knock me out? I had an epidural. And they're like, it takes 7 minutes um, for an epidural that was set up for just labor to be okay for a C-section. Like there's like this process that they have to do, and we didn't have 7 minutes. So, here I'm put under general anesthesia, and the anesthesiologist, ironically, this is his job, like hours of boredom punctuated by moments of sheer terror. He forgot to turn the oxygen on. So I wasn't getting any oxygen after I was knocked out. And he took a little while to figure out why my oxygen saturation was dropping. Then I hemorrhaged on the table because they had given me drugs to stop the contractions because she was losing her heart rate during the contractions. I finally got out of the OR, and as I'm just starting to come out of the anesthesia, a nurse says, "Are you having any pain?" And I'm like trying to do a "where am I?" and then a body check. I'm like, a little. And so without asking if I wanted any pain meds, she shoots pain meds into my IV. I'm the type who you show me the pain meds, and that's typically enough because I'm super duper sensitive. And I promptly stopped breathing. And so my husband is standing next to me with the baby, and the nurse like gave me the drugs and left. And here I'm stopping breathing. My husband's doing sternal rubs to wake me back up, to get me, you know, alert enough to breathe again. I can see why somebody would go into the freeze, because talk about being out of control. I mean, gosh, having all this stuff done, and it's like, oh, forgot forgot the oxygen. Oops, for oops, overdosed you. Oops. I felt like I missed something with that delivery, not being able to, even be alert for the C-section.
Do you remember kind of moving through it to like a fight or flight? Like, did you get super angry or super sad or super like how did that was it slower? Was it like how did you go through how did you move through it?
I went through quite a bit of acupuncture to help with that. I also have friends who do craniosacral therapy because I also do craniosacral therapy. So working with them and combined with the acupuncture really helped me to kind of pull through a lot of that at that time, because that was 25 years ago at this point. What things do you suggest for people who are having issues like that?
So we need to identify it and also just the gaslighting that occurs that like so what you have a baby now like so who cares what your experience was as a mother because I mean hopefully you have a baby now sometimes like we didn't even talk about trauma of loss or
Yeah.
all the other things but it's so minimized it's like our bodies are these transportation vehicles where they're just like look at your end product. You're fine. Everything's fine. Like, why are you complaining? Why are you upset? That can be also incredibly disempowering. I love how you had said you missed it. Like you weren't even able. It was incomplete for you.
Mhm.
So like that's such a really good deep way to describe that how can we move through something that we don't even know how we experienced it. When you would ask like what to do, it's like, okay, we know this is occurring. Like it has to be like not just for me as a clinician, but me as a human. Like every mom needs to be like, you have this baby and it's all about the baby. No offense, baby. But like there are times when we have babies come in that I'm like, does anybody else want the baby? Because I am going to focus 1,000% on that mother. And
Mhm.
sometimes, depending on the situation, I might not even ask about the baby, might not ask about baby's name, anything to do with. This sounds kind of harsh. Baby doesn't remember. Baby's getting cared for, but the mom, I need to fully attend to the mother. Like
Mhm.
it's almost like my 1,000% of my energy has to be um, to the mom. And this was, I'll actually even go back to when I worked in early intervention, where I'm like, this is wild. I'm here for the kid, but what services do we have for mom? Like
Mhm.
this is just we need to do better. So the first of just knowing, looking for it, kind of having it in our it's like we almost have to get rid of this blissful new motherhood thing that everyone's
Mhm.
supposed to be in. Like, and yes, I see like it can occur. I don't want to belittle anyone's experience if they had a wonderful postpartum experience, but it just kind of takes away if we're not feeling well enough to bond. Like, how could you, when you were fighting for your life, feel like you were able to bond, right? Like,
Mhm.
because there's those nervous system kind of buckets, and I mean I know you're highly like so well bonded with your children, and but how at the time are we not taking into consideration what moms are going through
Mhm.
and having just a little bit of like, they need a safety net, they need someone asking and making sure that we're supporting their experiences in a non-shaming or blaming way.
I don't know if you want to discuss the trauma that women have with miscarriage. So early on, under 20 weeks, it's considered a miscarriage. Over 20 weeks, it's considered a stillbirth. Oh, and then if you want to throw on top of that the current political climate, where we're going to be seeing a whole lot more as far as stillbirth or fetuses that are non-viable that are now needing to be carried to term. So the trauma of that poor woman, and I had a patient a couple years back. She was extremely religious, and she went to some OBs that were also extremely religious, and I can respect that. But she had her anatomy scan at 20 weeks, and there were no lungs. The lungs had never developed. And this woman had tried and tried and tried and tried to get pregnant, and she had miscarried a couple of times, and she was so happy that this one was going well, and she made it to the 20-week mark, and she goes for her scan, and there are no lungs, and there are other abnormalities as well, and um, the fetus is non-viable, and she's over 40 years old, and she's told by these Catholic OBs that it is a sin to induce labor. So when I saw her, she wanted to come to me pre delivery so I could help prepare her pelvic floor for delivery. And she looked like she was about 14 months pregnant. I mean, she looked like she was carrying twins because she had polyhydramnios, which is excess fluid in the abdomen as well. And I'm looking at her in horror that here she is looking like she's carrying twins or triplets. And um, I'm just trying to prepare her for birth. And she knows that the moment the cord is cut, that baby will die immediately. And she's carrying that and carrying that and carrying for months and months and months at this point because she didn't, she found out at 20 weeks, had another 20 weeks to go.
And how is not that not weighed against her, like her own, the physiology of that mother? How was that allowed for her health? Not
Right.
only the emotional, but even the physical. It's
Right. And having been raised Catholic myself, this really irritates me that, you know, I had learned back in catechism when I was younger, the priest said it's all about the mother. The mother can go on to have more children. We don't know what that child would do if that child was born. So it's about the mother's life. And so if there's something wrong, we should protect the mother. But that just doesn't seem to be across all of Catholicism.
And why can't we have choice? Like, why are we not given information and choice as like the humans that we are? How is that something that we are not given?
I see this as going to be creating a lot more trauma in the postpartum population. And are these women even considering themselves really, are they considered by society as postpartum when they don't have a child? More research that I came across is the Netherlands is the only European country that has formal national guidelines for childbirth related PTSD.
Sounds about right. Isn't that- They also did some really great stuff in education recently, too.
So, what treatments are you aware that are out there for people who've been suffering from trauma?
It's really being aware and being able to help find the support that the mother wants. It's giving choices. Always, always, always the best way to help someone get control is to offer a choice. If they're super frozen, sometimes we have to wait. And this is where it gets a little interesting because, like, where can someone consent to treatment if they're not responding to me as a professional? There's, differences state to state on who can use ammonia salts to kind of like help salt them back with the fumes of ammonia. So there's a lot of kind of talking that's done and kind of trying to ground the person to have them come back. And so helping patients get through our tools are talking them back to us, knowing that they might then become a little disruptive because we know that if we're bringing them back and they had some feelings that they went deep, now they're coming forward, they're connecting with the experience that we might have inadvertently triggered. Which again, there's all these things like how not to trigger someone. It's impossible. Triggers are they're individual. You don't,
Hmm.
I don't know what somebody's trigger is. There's no possible way besides not treat that person. If someone else hurt someone, which is almost always what happens when I'm working with someone on the table and there's a trauma response, my brain has to go, remember, someone else hurt this person. So, and every once in a while, it'll be identified that I hurt someone. I was like, well, I'm incredibly trained in what I'm doing. I triggered someone, yes, but I have never ever woken up and gone, I'm going to hurt someone today. My goal is to always help empower someone and help them get as good as they can with the tools that I have if they so choose. So, trauma response, it's happening on the table. I'm physically removing my hands because they can no longer consent because we go through consent all day long, informed consent. And then talking back into like helping them come back into the room and then processing through, okay, it's up to the patient to tell me what they want to tell me. It's up to the survivor to be like, this is what happened. I think it's better, it's cathartic. The more moms that we can have discussing their birth stories in a safe and supportive environment with people that don't minimize their experiences, oh my God, that'd be healing, right? It would be
Hmm.
healing in person with maybe some anger, grief out where, like maybe we do a little kickboxing or like cry fest or like, those rooms where you break up stuff. And if we know this as clinicians, if we know this as fellow moms, where we can kind of identify, okay, this is where they're at, then I have to go, okay, Lauren, you have to stand super tall right now, which is why the yoga works really great because I can go to yoga or I can go in mountain and like no matter what happens around me, I'm still a mountain. Wind can blow, things can get crazy. I am still a mountain. I'm going to be here and I'm going to like be here for that patient. And however, it's not always positive. Believe me, like there's some pretty wild stuff that can occur, but I'm still going to stand or sit in my mountain pose and I'm going to be as responsive as I can, taking care of myself first so I can take care of whoever is having a traumatic response. As soon as we're working through, it's who do you want to work with? Is it a religious team that you want? Who can we pull in? Are you wanting, behavioral health or mental health or mom groups or postpartum depression resources? Like that, postpartum depression can be very difficult for moms to align with or feel like that, like it's very difficult. There's stigma, still stigma.
Evidence-based treatments for PTSD are, can be trauma-focused cognitive behavioral therapy or EMDR, the eye movement desensitization and reprocessing. So those are other things that can people can get through psychology as well. So if they saw a counselor for something like that, somebody who's trained, that can be really helpful to process some of the trauma, because the trauma isn't necessarily just with the birth. There's, as you pointed out, okay, well, this person had been raped. And then, you had discussed previously when we were talking about doing this during pregnancy, the rate of trauma that happens just domestically within the household.
Like everyone that comes in gets 988, so you can call 988 for mental health services or just to talk to a mental health counselor. There's also I'm blanking, you could also text, which I think is really great too. So these are ways that someone can privately reach out to a trained professional just to get resourced and supported, and just so no one feels alone. So nobody, just part of this work, which I'm so excited for you doing this, Mary Ellen, is because like just letting others know that there's no stigma and this happens and there's help, or there shouldn't be stigma. I think there is still very big stigma. The blame and shame is just unbelievable. And so if there's a way that we can just make this more commonplace, that everyone knows, like this whole happy mommy postpartum magical land is just another way that might be making a mom not feel good about herself or her experience. Maybe not even with birth trauma, right? Like it's like
Being a parent is traumatic unto itself. Well, and then there's an infant who's colicky, that, a person can't settle and feeling inadequate. There's the trauma that I see quite a bit because I do a lot of work with um, breastfeeding and the baby having difficulty latching. So I see those moms who are struggling. They may have a really low milk supply and they feel like a failure, like their body has failed them because they couldn't produce milk for their child. And so seeing, the constant trauma with, struggling to get a baby who's either having difficulty latching or the mom's having difficulty producing, that, I mean, those types of things, and then throw in the sleep deprivation and stuff. That's all little t
yeah.
traumas.
Mary Ellen, I had it for who's at my first delivery. I we weren't sleeping. I woke up to this to being it was quite painful to being milked like a cow because I didn't have my milk didn't come in very well, if at all. So I was sleeping and then I wake up to someone who is now pumping my breasts without my consent while I was sleeping. I know it was the wildest thing ever. And she's like, "No, we
Oh,
need to get you breastfeeding." And I was like, I what? I was sleeping. You wake up and you're half asleep. You're like, what? I don't. But you're so out of control at a hospital. There's no. Every doctor needs to be hospitalized. Every nurse, every care provider needs to be hospitalized in a way that you don't. You really. It's not set up that you feel like you're in control or you have choices. That should have never happened. I should have never been milked without my consent. But this is the thing. You're no longer a person. Now you're a mom, and your whole role is to provide the next steps for your child. Like, my body doesn't matter. Like, that's just what it kind of felt like, or that was my
wow.
experience with being postpartum. Like, listen, like, you're just doing your role here. Like, this, let's get you breastfeeding. Like, it was such a big goal. But I was like, wait, did anybody ask if it was my goal? Because at that point, I was like, I just want to sleep. Like, no one's intentions is to be hurtful. Like, everyone's goal is just what we think the goals are. So even kind of stepping back, choices, options, what do you want? What is your goal? Like bringing it back to the person that we're working with to be like, how can we help you be empowered with information and given choices so that you at least feel like you have some autonomy. And like sometimes when people take my course, they're like, wait, I did not think, like, everybody wants this, like, oh, I touch them here, 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 and here, and then they're back. It's magical. We all want a fast fix. We all want, do these things to get X. And that's not how it is. There's a lot of work that we have to go through, and patience and time, and it's more soft skills than these techniques or procedures. So our culture and our society doesn't seem to value that very much. I think if there was one thing I wish I could help the whole world know, is that our bodies try to protect us, sometimes in ways that we don't want our bodies to protect us, or that makes us look weird or makes us do weird things. But it's literally just knowing that there's physiology, and there's like very physical things. Like, you're not weird if you're having a trauma response. You're not weird if someone else hurt you and now you're blamed. You're not weird if you experienced a birth or a pregnancy that wasn't the magical one. Like, that it's not your fault. Like, none of this is your fault. That there are options for you, that there's information, and there's people out there to support you and to listen to you and to hear that what your experience was valid. I think that's my biggest hopeful, like, take home of, like, you're not alone and you have choices. You're not alone and you have choices. So thank you, Mary Ellen.
All right. Thank you, Lauren. And we will see you guys next time. Bye.